Welcome to Beyond the Data. I'm Dr. Phoebe Thorpe, and here with me today is Dr. Mantell from the Robert Koch Institute in Berlin, Germany. Thank you so much for joining us.
Well, thank you for having me.
Yeah. Today's session was about global immunizations. Some vaccines have been around for a while, but today's session really focused on new vaccines. What are new vaccines and why are they good?
Right. I mean, we've been using vaccines in the expanded program of immunization for decades, but they were limited to about 6 antigens. Now, in the last decade, we've actually been able to come up with vaccines against really severe childhood diseases, such as meningitis, such as pneumonia. There is now also a vaccine against, the second vaccine that we actually have against cancer, human papillomavirus vaccine. There is a vaccine now against typhoid, which is a typhoid conjugate vaccine. So really what we're seeing is that we're having vaccines now against major diseases that affect children and will enable us already to reduce childhood mortality significantly. So all of this is new, and what we've been doing in the last decade is to actually ensure that these new vaccines are also implemented in those countries which usually wouldn't have had access to the vaccines.
Mm-hmm. And speaking of access, in the session we learned that globally the vaccination rates are around 86% for the old and new vaccines. And so the question a lot of people ask is, if you're only at 80% with the current vaccines, why would you add more or new ones?
Right. A very good question that we're being asked relatively often. But I think what we've done in the last decade and what we've seen is that there was an enormous investment with these new vaccines, which are more costly, into systems to deliver those vaccines. So we've seen a lot of investment in cold chain and logistics, in training of healthcare workers. And so the experience of most of the countries today is that they've introduced at least one new vaccine in the last decade. And with this, the opportunity cost of introducing yet another one will be relatively small. Mm-hmm. And then there are still diseases out there which are terribly dangerous. And just think of HIV/AIDS and think of tuberculosis, where we're eagerly waiting to get a new vaccine. And for the third big disease that is mostly prevalent in Africa and kills the children there, malaria vaccine, we now finally do have a vaccine, although it's not perfect, but there is something at hand that we can introduce there as well.
So it's about saving more lives. Yeah, there's no doubt that vaccinations are good investments. We heard today that for every $1 invested, they return 16, and that's just looking at when you take care of the kids when they're sick, and then the parents' income lost during that time. So, but many countries are having some difficulty making those investments. What have you found has been the most convincing for the ministries of health and ministries of finance to make those investments?
There's a number of things. So first and foremost, the ministers of finance need to be convinced that the disease is actually prevalent in the country. So even though it may be in the region, they would want to have data, surveillance data from the country saying that this disease is haunting us. If that is the case, then it is also, are there recommendations? And WHO has an international body that meets twice a year and sets recommendations for the world for immunization and has representatives from all regions in the world. So if that body actually says it would be a good idea to introduce that vaccine, that is also resonating quite well with the ministers, both in health and finance. And then there is the occasional neighboring country that has introduced a vaccine, and then the population would, be able to demand that vaccine also from their own governments. And of course, whenever there's an outbreak of a disease, even if it's not an outbreak of a vaccine, that we have a vaccine against right now, but that usually also stirs some momentum to work towards introducing other vaccines.
So it sounds like it's both a supply and a demand situation.
It is.
Yes.
It is always.
The other thing that we heard about was inequity in the vaccines. Can you speak a little bit about how the countries face inequities?
Right. As we said also in the talk today, there is inequities between countries, and here what we're seeing is actually that the middle-income countries, those that are not supported by the international community, Gavi for instance, because they have a too high gross national product per capita, they are actually trailing behind now. And what we need to do is really to support those countries, and there it's less financial support, but it's more support in procurement, in being able to negotiate prices with the manufacturers so that they come up with a reasonable price for the products that they want to introduce. On the other hand, there is inequities in countries, remote communities, but more and more also urban communities, slum communities, in which the health infrastructure isn't there yet, and where we need new approaches, flexible approaches, mobile approaches, and where often the governments are not in place to actually serve these populations. So we're working very much with community-based organizations who have a better access to these populations in order to provide, a good service, including the new vaccines.
Yeah. So you've talked about some of the problems, and I noticed I remember in the session they brought out some people in the slums may not have a legitimate right to request the vaccine because of the way the government system is currently set up. So what are some of the ways that they're overcoming that?
Well, as I said, if it's the government services that are not able to deliver these, then
the
community-based organizations, the other NGOs, non-governmental organizations, would be stepping in. And again, from Gavi, there is a CSO consortium, a huge pool of non-governmental organizations and civil society organizations that work together in immunization, but also in other health interventions to provide these services to the populations in need.
So piggybacking the immunizations with other needs, yes,
Correct.
Making it more synergistic.
Right.
Yeah. So if people are interested in finding out more about what's going on, where would they look?
Certainly, as we're here in Atlanta, I would suggest to go to the CDC website. There's ample scientific evidence and other, but also then the World Health Organization, Gavi, and for those that are interested in more financial aspects of the issues, economic aspects, the World Bank website. All of these would be interlinked, but there is it's a good start to.
There's all good places to
this
go,
information.
good resources. Yes. Thank you so much for your work and for joining us today.
Well, thank you for having me.
And thank you for joining us. See you next time for Beyond the Data.
There are up to 8.3 million children in daycares, preschools, and other early care and education centers in the U.S., and people assume that these early care and education centers are safe places for children to learn and grow. But what if we told you that's not always true? Because right now, up to 1 in 8 children could be in a child care building that hasn't been properly assessed for harmful chemicals. In most states, there's no clear process to make sure early care and education centers are located safely, so they've been in or near some pretty dangerous places, like factories, old gas station sites, and dry cleaners. Children may be at risk of contact with some very harmful materials, like mercury, lead, and radon. Children are more sensitive to these materials than adults because their bodies are still growing, and they can have serious and irreversible health effects, including kidney damage, learning difficulties, and cancer. We know you already work hard to protect children's health in your state, and you can build on those efforts to make sure that early care and education centers are located safely. We have resources that can help your state develop an action plan and build important partnerships between different sectors, like state health agencies, policymakers, and licensing agencies. So together, you can make environmental safety a key consideration when a new center is being approved. Partnering together can prevent potential tragedies and has other big benefits, like building trust in communities and lowering legal and liability costs. Learn how to protect children in early care and education centers and create an action plan for your state, because our kids are worth it.
Meet the Dots: Mom Dot, Dad Dot, Grandpa Dot, Auntie Dot, and Little Dot. They have dreams for their family and for Little Dot. The Dots are part of a community. They're building relationships with friends, family, community members, and professionals in early childhood, health, and other community organizations. Together, they are all working toward goals for all the Dots and for their community. We're talking about family engagement. It is most powerful when it is led by families. It honors everyone's strengths and interests. And it is grounded in mutually respectful relationships. And it nurtures family and community connections with two-way communication. Family and community engagement have long been at the heart of early childhood development efforts, and we all know from research and experience that family engagement works. That's why we've developed tools for you to enhance family engagement in your community. You can find tools that offer a shared vision, common language, and strategies for partnering with families. To learn more, check out the National Center on Parent, Family, and Community Engagement.
I've worked at CDC for 8 years. My family is from Sri Lanka, and my parents immigrated as a result of civil war. My mother is a physician, and while I was growing up, she held health clinics in refugee camps. Seeing people in these camps opened my eyes to many public health concerns, including the lack of access to safe water and sanitation. I realized then that I wanted to help people live safe, healthy lives. I work as a public health engineer in the Emergency Response and Recovery Branch with a team of experts in water, sanitation, and hygiene. We respond to emergencies that leave populations vulnerable to the spread of waterborne diseases, conduct assessments in camps to make sure people have adequate access to sanitation and safe water, and a lot more. In 2017 alone, I deployed to Sierra Leone after the mudslides, to refugee camps in Bangladesh to assess access to things like water, soap, and latrines, and to Ethiopia to help control a diarrheal disease outbreak. One of my proudest moments was in Tanzania during a cholera outbreak. Chlorinating water is a cheap, effective way to kill germs and make it safe for drinking and save lives. By providing chlorine tablets and teaching proper dosage techniques, we provided safe water to thousands. In the end, we were able to contain the outbreak. The ability to help so many people is what makes CDC and my job great. I'm Manu Rajasingham, and I am CDC.
For me, this is the moment where I actually start asking questions. And so you sort of pause for a moment and you ask the parent, so tell me more about that. So I'm hearing you saying that you don't want to give the vaccine. Is there something in particular that is making you think he doesn't need it? Or, why do you think your child doesn't need it? And let them explain sort of more about where they're coming from and what their position is. And then it really helps me to answer their questions or to figure out where I might be able to help redirect them to understand a little bit differently where I'm coming from. The most common one I've heard is, my kid's not sexually active yet, or they're not thinking about sex. And my answer to that is, oh my gosh, that's fantastic. They sort of look at me a little bit strange because they're like, why are you excited about that? And you're like, well, I'm excited about it because vaccines are something that you want to give before something happens. And so the fact that they haven't started having sex is perfect because it means that we have time to get in both doses of the HPV vaccine before they're ever exposed, which means it's that much more likely that it's going to protect them against cancer. And for most parents, that's enough to sort of flip the switch a little bit and change their mind.
Maya and Jay's parents both work hard to provide for their family's needs and their future. Both parents must leave the house by 7:30 a.m. to commute to work. Dad gets home first at around 6 p.m., but school starts at 8:30 and ends at 3. Like many parents, Mom and Dad need childcare to stay employed, but their combined income can't cover the costs. School-age childcare gives kids like Jay and Maya a safe, fun place to go when school is out. When people think of childcare, they often think of very young children. But 45% of all children served through federal childcare subsidies are aged 5 through 12. School-age care is paid for in a variety of ways, such as through parent fees, private funders, and federal subsidies and grants. The Federal Office of Child Care within the Administration for Children and Families supports low-income working families by providing access to affordable, high-quality early care and after-school programs. OCC administers the Child Care and Development Fund, or CCDF, and works with state, territory, and tribal governments to provide support for children and their families juggling work schedules and struggling to find childcare programs that will fit their needs and prepare their children to succeed in school. Through CCDF, an average of 627,000 school-age children across the country are served each month. During out-of-school time, which covers a time period before and after school, as well as school vacation weeks and summers. During those times, school-age childcare provides a place where children are safe and engaged in enriching activities. Summer is a critical time for working parents with school-age children. In fact, in the summer months, there is an increase in the number of children served through CCDF. Families need more hours of care, and their children need quality experiences that address learning loss and keep them on track for the school year ahead. Quality programs focus on continuous improvement in child and youth development, health and safety, family engagement, and other critical elements. And staff are trained in health and safety standards, such as first aid, CPR, medication administration, prevention and response to emergencies, and precautions in transporting children. This health and safety training gives parents peace of mind that their children are well cared for while they are at work. The nice thing is that school-age childcare takes place in many different settings across the country. Schools or centers, family child care programs, and in children's own homes. No matter where it takes place, school-age care gives children like Jay and Maya the encouragement to try new things and helps prepare them for a bright future. And there is a wealth of data that shows quality school-age childcare increases positive outcomes for children. With a little help, Maya and Jay's parents found both quality childcare and subsidies to help them afford it. Their family is just one of tens of thousands of families that can be strengthened through school-age childcare.
Wonder if you should get tested for colorectal cancer?
Yes. Is it really that common?
It is. Of cancers affecting both men and women, it's the second leading cancer killer in the U.S.
But I don't have symptoms.
It doesn't always cause symptoms, especially early on. So don't wait. If you're 50 or older, it's time.
But it doesn't run in my family.
Most often, colorectal cancer occurs in people with no family history. And think about this. Screening helps prevent the disease.
Really? How?
Screening helps find precancerous polyps so they can be removed. Remove the polyp, prevent the cancer. Screening helps find colorectal cancer early, too, when treatment works best.
Oh man, that test.
There's more than one screening test. You have options. Talk to your doctor to find the one that's right for you. Because colorectal cancer screening really does save lives.
I'm Stephanie Abdallah, and on behalf of the Army Surgeon General, this is your Army Medicine, Be As Healthy As You Can Be, Health Minute. March is Brain Injury Awareness Month. According to the CDC, more than 3 million concussions occur each year in the United States, and 64,000 of those patients are age 14 and younger. A concussion is a type of mild traumatic brain injury, MTBI, caused by a bump, blow, or jolt to the head or body that causes the head and brain to move rapidly back and forth, stretching and damaging brain cells. Full recovery is expected in patients that have sustained MTBIs. However, MTBIs can have serious effects on young, developing brains. Anyone who has potentially sustained a concussion should be removed from activity and observed for dizziness, unsteadiness, feeling foggy, dazed, confused, nausea, headache, fatigue, or just not feeling right. Anyone experiencing these symptoms should be evaluated by a healthcare provider. For more information, visit www.dvbic.dcoe.mil. Army Medicine, one team, one purpose, conserving the fighting strength since 1775.